Hi and welcome to this webinar with NIOM. My name is Amela Tulek. I am a dentist and researcher at NIOM. In this webinar, we will briefly discuss about dental erosions as a modern society problem. I'm showing here an overview of the points that we will talk about. First, let's define erosions and other types of tooth wear. So previously, erosion was defined as chemically induced progressive loss of hard dental tissue without the involvement of bacteria, meaning that this is a solely corrosive process caused by acid. And then later on, a new definition was introduced referring to it as a chemical-mechanical process causing loss of hard dental tissue mainly from erosions, and the term erosive tooth wear was accepted. So, what are clinical features of erosion? We know that the demineralization process initially starts at enamel surface layer and progresses further to enamel and dentine. Yellowish color, shallow and flat defects on tooth surface, or cuppings on molars, exposure of dentine, rounded edges, or chipping of tooth may be found, and this can affect one or multiple teeth. Other types of wear are categorized into abrasion, where a foreign object causes wear. These defects are gold brown in color and localized cervically. Attrition happens when teeth are in contact, both physiologically and exaggerated in some functions such as bruxism. Abfraction or non-carious cervical lesions are defects primarily caused by biomechanical forces generating stress in the cervical region, producing wedge-shaped defects. However, in one patient's mouth, we often see a combination of different wear, and it is that their interplay causes substance loss. For example, a chemical dissolution weakens the tooth substance that then becomes easily susceptible to mechanical wear, and patients mostly complain to pain, hypersensitivity, functional and aesthetic problems. So, what are causes and risk factors for erosions? These may be generally grouped according to the acid origin into extrinsic and intrinsic. Extrinsic are mostly acid sources from food and drinks related to some medicines or occupationally related, while intrinsics are associated with eating disorders and gastroesophageal reflux disease. Extrinsic factors are associated with today's modern lifestyle. For the first, where a major shift has happened, resulting in an extreme intake of acidic diet. And Norway has now actually positions high in the soft drink consumptions in Europe. And compared to some 30 years ago, the intake of those drinks tripled. Extremely popular in Norway is Pepsi Max, with Norway population being one of the biggest consumers in the world. And moreover, further predictions according to the current data are not brighter. It is still a growing trend, also among young generations. And a shift to an artificial sweeteners that are replacing sugar, doesn't make these acidic drinks less harmful towards teeth. Another worrying data is the steadily increased intake of popular sports drinks and energy drinks among children and adolescents, with poor regulations of the age limit and having in mind effects of such drinks on the general health too. Here I have a recent big data sample from Norway among age group 10 to 18 years support these findings. This is a study that collected data from 2017 to 2022, and we see an increase in consumption of such drinks in these age groups. Many studies point at some particularly susceptible groups with higher risk due to frequent and prolonged exposure. These are mainly occupation-related risk patients, such as these individuals working in battery industry or professional wine tasters, then patients taking asthma medicines, professional athletes, swimmers, individuals with vegetarian diet regime, individuals or especially children eating frequently sour sweets. On the other hand, there are intrinsic sources of acid, where the acid originates from the stomach, and this is often risk linked to eating disorders, such as anorexia nervosa, bulimia, binge eating disorder, orthorexia nervosa, and other eating disorders not otherwise specified. Reported prevalence in adolescents is around 12.5%, and it's more often found in women. Studies report that eating disorders in general are associated with more than 5% increased risk of erosions. Particularly, bulimia is associated with 8.5 high risk. Another condition, gastroesophageal reflux disease, where the stomach acid is in frequent contact with oral cavity due to the weak gastroesophageal sphincter, is found in 20% of world's population, and in some it can be present as silent reflux when it goes unrecognized. And now we will see some prevalence data. There has been a study from several years ago presenting some data on the global level, but as we can see, the data pool was quite limited since many countries lack to report numbers still. But among different age groups, some conclusions are broad and results vary. This may be due to still not standardized registration methods and scoring systems. But prevalence among children, adolescents, and also adults is overall high. In northern countries as well, there are reports mostly among adolescents, showing high numbers with valid reasons to be concerned. So, what do we do to identify risk patients? Here is a brief summary I'm presenting. We start with general anamnesis, where we ask about diet, some habits that can be related to erosions, development, use of medications, medical conditions, is the patient training in sports, and then the oral examination is done, where we examine surfaces, edges, is there any chipping, cavities, is dentin exposed, what about the pulp, is there any cuppings in molars, for example, and then these findings need to be registered. We use various grading systems, but here in Norway, it's common to use visual erosive dental examination, or VEDE system, and then we can use photos, scans, study models, or X-ray to register the erosions in order to be able to follow up the condition later. And when it comes to the treatment, it is always important to think about minimally invasive procedure, meaning that we will preserve as much as possible of the healthy tissue. And here there are levels of intervention according to severity. So there is a non-invasive treatment where we give patient informations related to this condition and try to reduce or modify risk factors and increase tooth resistance. The next level is microinvasive. This is operative treatment, but mostly with the composite restorative materials. And finally, invasive treatment, operative treatment with some prosthetic restorations. So when we have identified our risk patient, early prevention is crucial. So informing the patient is very important in order to understand what is actually happening and how these factors can be modified and reduced, and then to work on increase of the tooth substance. And how can this be done? So, for example, toothpastes containing natrium or sodium fluoride are in use, but with a relatively low effect reported. Even though we use them on the daily basis, there is still significant increase in the incidence of erosions. And then there are new toothpastes on the market with calcium carbonate, kalium nitrate, or tin fluoride that promise special protection against erosions. Uh, Various products on the market, they promise to have a good effect on the relief of pain, hypersensitivity, and to have a good erosion progression control. But however, few clinical studies can indeed confirm this. We at NIOM are now involved in a project with the aim of looking at the effect of different fluoride compounds in the treatment of erosions in vivo in a previously established mouse model. We hope that this will give us a better understanding when it comes to treatment selection. So as I mentioned, the following level would be operative treatment with some composite restorative materials. And when do we do this? So this is done when progression cannot be stopped non-operatively and when we have aesthetic or functional need. And the main aim is to restore the function and aesthetic and stop progression and preserve remaining healthy tooth substance. Such approach has some advantages. For example, it saves time and money, reduces incidence of iatrogenic injuries, increases survival of a filling, and generally has a good patient acceptance. And then finally, we can look for a prosthetic rehabilitation with some ceramic materials. So, new ceramic materials offer less invasive tooth preparations compared to some few decades ago. But however, preparation dimension is still dependent on factors such as material type, enamel quality, and tooth position. Thank you very much for watching this webinar. For any further questions and comments, please write us at niom@niom.no and visit our website, niom.no.